Great pleasure today to introduce Dr. Goldberger. Dr. Goldberger received his undergraduate degree in English and American Literature from Brown University, a medical degree from Yale, where I understand afterward, he completed his residency training in internal medicine at the University of Washington before going on to a cardiology fellowship in Michigan, where he did a research fellowship through the Robert Johnson Foundation for Clinical Scholars Program. Fellowship for 28 peer-reviewed papers and is a co-author of the long-standing interest in therapy and treatment modalities in patients at risk for sudden critical death and investigating the matters of care and resuscitation in hospital cardiac. I should point out that I learned from the Department of Medicine's Facebook page that this topic, or this paper that is going to talk to us about, the AHA's top 10 contributions to cardiology, which you may look.
Thank you. Good morning. Happy Valentine's Day. So, I have a few objectives this morning. The first, we're going to very briefly review the epidemiology of cardiac arrest. Secondly, we'll talk about prior resuscitation and speak to their implications and limitations. We're going to then talk about the reassessment of these investigations and recent investigations and their possible implications. And finally, we'll have time for some questions and hopefully some discussion about these ideas. So very briefly, cardiac arrest is a major clinical problem. The event is unexpected and surprising. Patients are challenging and outcomes are generally poor. Estimated about 570,000 arrests each year in the United States. And the best way to break these down is to think about them in terms of two types of arrest: in-hospital and out-of-hospital cardiac arrests. About 210,000 in-hospital cardiac arrests. I've heard Peter Kudenchuk speak to the impact of mortality, and he likens it to airplanes. So a 747 airplane with about 500 passengers. So to estimate the total mortality would have to be about 1,000 of these planes crashing every day, every year I should say, and about 3 crashes per day. So the impact of mortality is substantial. In hospital cardiac arrest, about 1 in every 5 out of 1,000 admissions of patients to the hospital will have a cardiac arrest. About 50% of them have return of spontaneous circulation. And ROSC is a term I'm going to come back to again and again during the talk. This basically means immediate survival, which is when you stop resuscitating patients, they have about 20 minutes of continuous pulses. And 15 to 20% of them survive to discharge. More often than not, the presenting rhythm is due to PEA or asystole, the rest due to VTAC or VFib. And recent estimates of survival of discharge from the journal show that, again, 15 to 20% survival of discharge is about the norm, which has only improved slightly over the years. Other estimates from administrative databases that came out of this institution actually show about the same amount of survival of discharge. And the problem with all resuscitation is that the long-term outcomes of these patients, whether they were resuscitated or not, remains largely uncertain. And by and large, we would expect that we know what we're doing during resuscitation. We're going to push hard and push fast, give epinephrine, follow ACS protocols. But the problem is, the reality is that at the bedside, there is a great deal of uncertainty, and duration plays a lot of that. So one of the greatest challenges facing clinicians is knowing when to stop and rest prior to terminating efforts. And we've all been in a situation out of code. No one really understands when to stop. It doesn't matter what specialty you're in, there's always this decision point, and you're asking yourself, when do we stop? And the problem is because there's actually no empirical evidence regarding an appropriate length of resuscitation prior to the termination of events. There's actually, I think, a long history of reluctance to continue efforts when you haven't had return of circulation early on during the course of the arrest. And it's extremely difficult to make this decision during the arrest for obvious implications. When you stop, the patient dies. So people have been looking at this for a long time. Edward Stemler, a cardiologist at the University of Pennsylvania, looked at this about 50 years ago. He's also a pioneer in the field of medical education. And he described this by showing that the duration of attempts has varied from a few minutes to almost 3 hours, but most efforts were terminated within 15 to 30 minutes. Susanna Bedell and colleagues at Harvard looked at this, and they found that 95% of patients died after resuscitation went on for more than 15 minutes. And made the claim that since efforts at resuscitation lasting more than 30 minutes appear to be uniformly unsuccessful, they should be abandoned unless there are unusual circumstances. Ken Value and the colleagues at the University of Virginia looked at this, and they looked at 313 arrests in a small series and found that survival, shown on the y-axis here, dropped precipitously over time, anywhere from 5 minutes or less to more than 20. And they found that, for instance, at less than 5 minutes, out of 51 arrests, only 23 patients survived. This dropped to less than 3% after 20 minutes, where you have 5 survivors out of a total of 146 arrests, and most of the arrests were actually conducted for longer than that. So again, arguments that we shouldn't be going for that long. Investigators in Taiwan looked at this in their own registry and found that, again, ROSC here, on patients who died, they found that it occurred 90% for patients who were resuscitated for less than 10 minutes, and half of them who were resuscitated for more than 30 minutes achieved ROSC. Mickey Eisenberg and Terry Mager at this institution synthesized this evidence in an article in the New England Journal asking the question of when to stop, one of the greatest subheadings I've ever found in a review article. And what it says is that prolonging efforts beyond 30 minutes is usually futile unless the arrest is compounded by hypothermia, submersion in cold water, or other identified and treatable conditions. And it's actually arguable that it's reasonable to stop after the patient's been in asystole for more than 10 minutes if there's no identifiable and reversible cause. Guidelines are certainly a moving target. Scientific statements admit, yes, there are numerous psychological and situations, factors that influence the time at which CPR is stopped, and this time point often is imprecise. However, it's very helpful information to have and could be useful for developing guidelines. So overall, we've actually looked at this evidence. We've come to rely largely upon case series, expert opinion, and small studies to guide our practice as far as duration of resuscitation. Current recommendations are limited. It's reasonable for determining efforts anywhere between 10 and 30 minutes. And these recommendations have actually had a large influence in our contemporary practice and have proliferated down, affecting the way we resuscitate patients. But these studies have severe limitations, and I would argue that we should look at these things with caution. So first of all, the problem is this. The problem is that these studies have examined all cardiac arrest victims, both survivors and non-survivors, and this is a critical point. If you look at both survivors and non-survivors, you're basically asking yourself, what's the likelihood of survival based on a real-time resuscitation, so the patients that survive. And most of these patients come back very early on during the resuscitation. So by looking at survivors in this study, you're going to find that short durations are associated with overall higher survival. For instance, if you have a patient that are coming back at 10 minutes and non-survivors are coming back later, it largely skews the distribution of survival toward the left, again, showing that short durations are associated with higher survival, which is what these other studies have already shown. This sort of invokes the challenge of endogeneity, which means that the length of any resuscitation attempt is inherent to the outcome of the attempt, whether it's successful or not. So if a patient comes back early, the resuscitation is over. No one's going to continue resuscitating a patient who has already survived. If the resuscitation is not successful, the doctor has to choose whether to go on or not. The choice is not there with survivors, but it is with non-survivors. The second problem is that there's no examination of cumulative survival or any examination of what would happen if you extended the duration. So in these prior studies, it's looking at Dr. Ballou's graph from the University of Virginia, although it shows a dramatic drop in survival over time, what you don't recognize is that actually 27 out of 50 survivors were resuscitated for longer than 5 minutes, which actually isn't too bad. Furthermore, 5 out of the 50 survivors were resuscitated for longer than 20. That information is buried within this graph, but again, it doesn't actually look at cumulative survival. The similar series from Taiwan showed that if you're going to look at this graph again and show here on the axis, the red curve shows cumulative survival with ROSC on the y-axis, what it shows is that after a half hour, you resuscitated 70% of your patients, but 30% of these will achieve ROSC only after extending beyond 30 minutes. Looking at beyond an hour, 10% will see this after 10 minutes. So again, cumulative survival has been ignored before, but actually plays a large role in how we interpret this prior literature. And the final problem is that these are small numbers of patients, small number of hospitals, single center studies. And we're unable to account for institutional differences in resuscitation care. Again, it's arguable that resuscitation duration is influenced by the way we practice in hospitals. And there's a correlation in resuscitation duration among patients within the same hospital. So what are the next steps? Based on this old literature, we wanted to do the following for our investigation. First of all, expand the sample. Look at a large number of patients at a large number of hospitals. Examine the variation of resuscitation in non-survivors. Ask ourselves, well, when are doctors choosing to stop the arrest? Ignore the survivors to figure out what happens when the patients aren't coming back and how we behave in that situation. And finally, examine the potential of extending the duration of resuscitation. Leverage the fact that there's variation and build on that. I just want to leave you at this time with a thought experiment. You have two hospitals. Okay? One hospital says we're going to stop at 15 minutes. The other hospital says we'll stop at 30 minutes. And later on we'll discuss what the advantages of doing it one way, what the implications of that might mean. Again, hospitals behave differently. So with any research in recent cardiac arrest, it's always helpful to have a registry of data. It's very obviously there's been numerous advances in the science and practice of resuscitation over the past 50 years, largely being from RCTs, but RCTs in cardiac arrest are actually hard to conduct, largely due to ethical reasons. Cardiac registries are also very helpful. So they come in two flavors, in-hospital and out-of-hospital. Yeah, with the guidance of resuscitation, the UK's National Cardiac Arrest Audit are large in-hospital cardiac arrest registries. The Resuscitation Outcomes Consortium Cardiac Arrest Registry, many of the investigators are here, is large, and CARES is the other large one. There are other smaller series across Europe and internationally. But we turned our attention to the Get With the Guidelines Resuscitation Registry, sponsored by the AHA. This is a large multi-center observation registry of all index cardiac arrests in hospitals that voluntarily participate in the registry. To date, it has about 600 participating hospitals on over 200,000 index cardiac arrests. It's the largest series that we have to look at this in a prospective way from secondary data. Information is collected by the review of cardiac arrest flow sheets, review of hospital paging logs. They look at the emergency use of code medications and how code cards are stacked, and billing charges. And they are able to abstract data based on those cases in the following way. Our endpoints for the study are two of the things that we've already drawn on: return of spontaneous circulation, or immediate survival, and survival to hospital discharge. The secondary endpoint, also quite important: what is the neurologic status of patients at the time of discharge? We start out looking at about 93,000 patients with index arrests at 537 hospitals over an 8-year period. We looked at pulseless rhythms, so pulseless VTAC, pulseless VFib, PENA, and asystole. We had several important exclusion criteria. First of all, we looked at patients in the emergency department and dropped them right away because in all likelihood, it's hard to tell whether an arrest that occurs in the ER is actually carried in from the outside, whether it might be part of an ongoing out-of-hospital arrest that just gets brought into the ED. Oftentimes you'll see this on TV when patients are being resuscitated and they're crashing through the ER doors. We looked at the patients in the OR, the post-anesthesia unit, and procedure areas and excluded those too because those aren't classically what we think of when we think of in-hospital arrest. They're also due to very distinct clinical circumstances, such as a catheter irritating the ventricle during a cardiac catheterization, causing transient VFib that could be promptly resuscitated. We also wanted to ensure that the hospitals that we're looking at actually had some experience with cardiac resuscitation. So we took all the hospitals that didn't have at least 10 or more arrests and excluded them. We also wanted to ensure reliable participation within the registry itself, so hospitals that had to collect at least 6 months of data or longer. We also excluded arrests that lasted less than 2 minutes. So oftentimes there's not actually a lot of certainty whether the patient is truly pulseless or not. They're receiving compressions when they're actually alive. So we wanted to ensure at least 2 minutes were going on of actual ACL's protocol to determine if this is a true arrest or not. And for obvious reasons, we exclude patients with ICDs, given that these are designed to terminate any kind of ventricular tachyarrhythmia before the arrival of a resuscitation team. And we did perform sensitivity analyses without these exclusions, and our results remained stable. We were left with 64,000 patients at 435 hospitals. So what we found was the following, that actually, based on the presenting rhythm, we found that most patients had PENA asystole, with about 20% having VTAC and VFib, which is consistent with national estimates. We found that almost half of them achieved ROSC, and 15.4% of these patients had survival to discharge, which is a little on the low end. Then we ask the question, designed the study was to determine the median duration of resuscitation. What is the median duration from a purely descriptive standpoint? We found that overall patients were being resuscitated for about 17 minutes, with a wide range, anywhere from 10 to 26. Survivors were receiving about 12 minutes resuscitation before they came back. And doctors were choosing to resuscitate non-survivors for 20 minutes, again with a large distribution, going from anywhere from 14, but not beyond 30 minutes. We then looked at the cumulative ROSC, much as we did with the other studies, and revisited them. And we found the following. We found that, again, 48.5% of these patients overall achieved ROSC. And we've also found that 41% of them achieved this at 30 minutes, but there's a small percentage of patients that actually required more than 30 minutes to achieve ROSC. We were actually surprised to find this curve looking the way it did. We would have expected it actually to be much more left-shifted in finding that patients should have come back, at least and would start to plateau at about 10 minutes. But we didn't find that. We found that, again, there's a non-trivial number that require more time. We then looked at this by presenting rhythm, and not surprisingly, patients with VTAC and VFib had a higher percentage of survival than patients with PNA systole, with the obvious advantage that these guys have the benefit of having been defibrillated, which is prompt survival. But again, the shape of the curve is largely the same. We then turn our attention to the resuscitation in non-survivors. So how long are doctors choosing to resuscitate patients before they choose to stop? What we found was a large distribution of non-survivors, about 33,000 in total. What we found was that most of them were stopping at within 30 minutes, but there was a large percentage, I would say 1 in 4 patients, didn't have the opportunity to be resuscitated beyond 30 minutes. They weren't even getting that long of an attempt. So the bottom line from descriptive analysis is that, yes, there's a non-trivial number who are not surviving by 30 minutes, with a large number of patients who aren't even being given that long. So overall, what we found is that there's a length of resuscitation among non-survivors that varies substantially across a large number of hospitals. Understandably, we don't have a lot of evidence to guide ourselves as to when to stop. There's a non-trivial number who need more than 30 minutes to survive the event, and attempts at most are rarely extended beyond 30 minutes. So we actually leverage both of these findings to construct the next set of analyses, which is at the hospital level. So this is a key concept, and I mentioned this earlier. There's a correlation in duration among patients within the same hospital as far as resuscitation goes. And resuscitation durations for a patient in any given hospital may not be entirely independent events. There's obviously the local medical culture that will influence anything we do in the hospital, and the house staff should identify this when they rotate from hospital to hospital. There are certain things that these hospitals do things that are not the same from university to the VA to Harborview, or even the outside clinics. They're oftentimes intangible, but it's very clear to know that these hospitals just are not behaving exactly the same way. And to look at differences across hospital, we have to look at these things from a multi-level model to examine the potential differences in the practice of resuscitation across hospitals, how these hospitals are different. I just want to take a break just to make sure that we're all on the same page about what a multi-level model actually is. So imagine I asked you, as a researcher, to say the blood pressure at doctors across all Seattle hospitals. Okay? From an individual level approach, you would just go out, take blood pressures of all the faculty, and you'd find that the mean blood pressure being 138 is not unreasonable, but again, there's a large variation. Some of them are quite high, some of them are quite low, almost cardiogenic shock. But looking at this from a multi-level approach gives much more inference. It allows us to examine individual level variation at a clustered level. So again, remember, there are several hospitals in Seattle, Harborview, the VU, the VA, Northwestern Valley. They all have different mean levels of blood pressure. For whatever reason, patients at the VA may be more hypertensive because the patients are largely very challenging. Patients at Valley may have a better time and maintain a little bit more of a normotensive attitude. But there's a lot of variation across the board, okay? And there's individual level variation within hospitals. And to ignore this variation, to ignore this clustering, will lead to incorrect inferences. And you have to sort of pay attention to what's going on. This happens all the time. This is a very common method in social sciences. They look at test scores in pupils. They look at test scores of overall students in classrooms. They look at doctors in hospitals, patients within doctors in hospitals. The levels can go on. But the idea is that you have to look at certain data within a nested fashion. These models go by several different terms. They all sort of essentially speak to the same idea that it's necessary to analyze certain data in a clustered manner, with each level having its own variability. So for our analysis, we're looking at patients at hospitals. It's a very simple two-level model. And the key question is, does how long a hospital attempt resuscitation lead to successful outcomes? That's what we're asking the question. Does length actually matter? Using individual data doesn't answer this question. As I've talked before, the problem of endogeneity. Again, the length of attempt is inherent to the outcome. If you look at just an outcome of a resuscitation, you're going to find that patients survive earlier on. Doctors don't have a choice of resuscitating these patients longer. You can't examine the potential for extended duration with individual data. So the question is how best to determine what happens with long attempts in hospitals. So our exposure variable is the following, and this is a critical point. What we're asking ourselves is saying, well, how long should hospitals go for? We're going to look at the longer resuscitations in these hospitals, which will be best reflected by the length of attempts in patients who didn't survive. So when patients survive early on, the resuscitation rest is over. But you're asking yourself, well, doctors can choose when they want to stop or not. So the hospital the doctors that resuscitate patients for longer, those non-survivors, is a good proxy for a lengthy attempt. And we're asking ourselves, within those hospitals, how long did hospitals try to resuscitate patients who died? And looking at the survivors within those hospitals that differ. So the hypothesis at the time is to ask ourselves, patients in hospitals, which on average practice longer efforts in their non-survivors, have better survival compared with hospitals who practice shorter attempts in non-survivors. So looking at survival within hospitals that behave a certain way as to stopping, as whether they choose to stop early or later. We're examining the potential of extending the duration. To do this, we designed hospital quartiles. So we actually stratified hospitals into quartiles and examined the potential impact of longer duration. And we stratified them by their increasing median duration among non-survivors. So 4 hospitals, 1 through 4, and they all could be any hospitals that we have in our system here. Hospital quartile 1 will have the shortest median duration of non-survivors compared to hospital quartile 4 with the longest. Again, each of these hospitals has the same number of patients, it's approximately the same number of hospitals, all with a similar number of characteristics. So patients who are at hospital quartile 1 are just as sick as they are at quartile 4, and we'll sort of see what happens. So the breakdown looks like this. Hospital quartile 1 had a median duration of 16 minutes, 113 hospitals, with about 14,000 patients. And the duration increased over time. What we found is that overall, hospitals in quartile 4 had a 50% longer median duration compared to hospitals in quartile 1. And this may seem like a modest difference on the surface, comparing 25 minutes to 16 minutes, asking them to resuscitate for 10 minutes longer on the median. But imagine this from a clinical perspective where these are distances across hospitals. So clinically, what you're saying is asking doctors to resuscitate all their patients in that hospital for 10 more minutes before stopping. And these additional minutes may have substantial implications. And this is time you could spend evaluating responses to therapy, seeing whether the response to what you've done, offering additional therapy that may help support ventilation perfusion. This is time that could be well spent. We adjusted for several things in our analysis. And we didn't just throw the kitchen sink in. There's actually published risk models for in-hospital arrest. And we looked at adjustment for patient-level covariates that may be linked to outcomes. We built on prior models. We looked at things like shockable rhythms, which obviously have a better outcome. Patient age is extremely important for obvious reasons. Looking at the race and looking at illness category, whether they're surgical patients, medical patients, surgical cardiac patients, medical and non-cardiac patients. We then looked at pre-existing conditions. So patients were quite sick overall. They may have no pre-existing conditions. They may have had an MI during their stay. They could be hypertensive, liver failure, renal failure. They could have cancer. They may be victims of a major trauma or renal insufficiency. They may have had a stroke. We adjusted for all these things. We then went on to look at things that were done to patients during the time of the arrest. So whether they received an airway, whether they received a chest tube, whether they actually received pressors or not. Then we built on the model to look at, the arrest is obviously in most cases in the hospital witnessed, but it's important to know when a patient actually does have arrest. People should know about it. where it is, I mean, arguably arrests in the ICU are largely different than patients who are arresting on the floor or even a tele unit. Looking at the time from admission to the event. We looked at patients that were having arrests on the weekend or at night. We also wanted to know quality metrics, so what was the time to first compressions? We also looked at the study period. Arguably, we looked at this over an 8-year period of time, but things have changed in resuscitation science over that time. They have the benefit now of possible using hypothermia, they have pulseless waveform capnography, other measures of ventilation perfusion that we've actually come to use to help the outcomes. And we actually then decided to look at just some hospital characteristics, and where the hospitals are, whether they're urban locations or rural. And the availability of CT surgery or the ED speaks to the actual advancements of the hospital, or possibly the resources available to the doctors practicing in those hospitals. This is what we found. So the total cohort of all these hospitals, we wanted to know what was their survival rate. What was the adjusted survival for these patients? What we found was that the adjusted survival rate for patients overall ranged from 50.7% in patients in the hospital that resuscitated patients for longer, compared to 45.3%. The models enable us to have risk ratios, which are essentially odds ratios with a slight difference. But what it shows us is that patients in quartile 4 had a 12% higher survival compared to patients in quartile 1. And this trend was significant. We then turn our attention to the survival of discharge. And again, what we found was that patients didn't survive the discharge as to high an extent, again, but they increased their survival discharge in patients in quartile 1 from 14.5 to 16%. The risk ratio in this showed that, again, patients in quartile 4 compared to quartile 1 had a 12% higher risk of surviving discharge, or 12% more likely to survive discharge. And again, this trend was significant as well. We then looked at rhythm by ROSC. What was the presenting rhythm? How did that affect survival? What we found was that looking at PEA and asystole, patients with VTAC and VFib compared to PEA and asystole had a higher adjusted survival rate. The patients with PEA had a significant increase from 41% to about 48%. The patients with ventricular tachycardia and ventricular fibrillation did not have that same. So patients with PEA had a 50% higher likelihood of survival in quartile 1, quartile 4 compared to quartile 1. The trend didn't hold up for patients with VTAC and VFib. It approached significance but didn't quite make it. We then looked at survival and discharge by presenting rhythm. We found similar things, that patients who had PEA and asystole had a significant trend in survival over the quartiles. In fact, a 20% higher likelihood of surviving the discharge in quartile 4 compared to quartile 1. Patients with VTAC and VFib did not have a significant trend. Their survival remained about 32%, regardless of the duration. So what we found from the hospital level analysis is that patients at hospitals with a longer median duration of resuscitation in their non-survivors had better outcomes compared to those in hospitals with shorter attempts. We're basically asking ourselves, in the hospitals that behave differently, how is survival being affected? What's the potential impact of extending the duration of resuscitation? And this was independent of patient characteristics. Regardless of age, pre-existing conditions, we adjusted for all these things. And finally, there's a particular benefit in PEA and asystole, which was a little bit surprising but somewhat understandable. If you ask yourself, these patients are arguably sicker than patients with VTAC and VFib. These are the patients, exactly the kind of patients that we want to benefit for a longer time. It may take longer time to figure out why they're sick, to identify reversible causes, and to give them more therapy. These patients may take actually longer to respond to the therapy you've given them. This is time that we spent sort of figuring out what the cause was and potentially helping them. So neurologic outcomes is extremely important. So we're saving a lot more people potentially, but how are they doing overall? When you look at neurologic outcomes from resuscitation research, it's usually divided into a scale called the Cerebral performance category. And this is a controversial issue for the following reason. It's based on 1 through 5, and it's an ordinal scale. Okay? Based on this construct, patients with a CPC score of 1 have good performance, or mildly disabled. Overall, they're conscious, they're alert, they're able to work, they're able to live their lives with only minor neurologic or psychological defects. CPC scores of 2 are a little bit worse off. They're still conscious, able to work, but in a sheltered environment, but they're still able to perform their ADLs independently. After that, things get worse. Severe disability where they're conscious, but they have limited cognition, major deficits, and they're fully dependent on others to help them out. And coma and vegetative state are self-explanatory. I would argue that this scale is okay, but the difference from going from a 1 to a 2, I think, is a lot more, or maybe a lot less important than going from a 2 to a 3. It's an ordinal scale. This is what we have. And based on prior literature, a favorable neurologic outcome is defined as a CPC score of less than or equal to 2. So overall, what we found was that we had neurologic status available for 8,700 patients, which is a very small subset of the overall population, but it actually reflects 88% of the people who survived to discharge. About 9,000 patients survived to discharge. We had neurologic status and CPC scores available for most of them. What we found was that the proportion of the CPC score of 2 in the overall sample was 80.6%. So 80% of patients in our sample had a favorable neurologic status. And this actually had a trend that actually decreased slightly over the time from 15 minutes to 30 minutes and beyond 30 minutes. The trend went from 81% to 78%. But this trend was not clinically significant at all. So overall, looking at the overall status of neurologics, from a neurologic standpoint, neurologic status remained the same with increasing duration of resuscitation. We then looked at this by rhythm. What we found was that patients with PEA and systole had a lower proportion of CPC scores less than or equal to 2, and VTAC and VFib had higher, which is understandable. What we found was that 76% decreased to 74% going for Fox time, and then 88% for VTAC and VFib. But again, this was not significant at all. So overall, we found that longer efforts were actually not associated with significant detriment in discharge with a favorable neurologic status, even with PEA and asystole. We found that hospitals with longer efforts had similar neurologic outcomes and higher survival. So arguably, you're actually increasing the absolute numbers of patients with favorable neurologic status. And finally, this may seem surprising, it was at least to us, but if you think about it, these are in-hospital arrests where you have continuous chest compressions, continuous supportive measures. So the quality of resuscitation is actually better, I think, than an out-of-hospital arrest where the patient might be down for a long time before they achieved circulation that was continuous or able to perfuse their brain. So the key question is, we found that there's higher survival at these quartiles that practice longer durations. But the question is it the duration of these hospital arrests actually making a difference? Or is it something about these hospitals that we just don't know, that they're actually behaving better? Maybe they have larger adherence to guidelines, maybe they have better code team leadership. We don't know what the reason is. Maybe it's just better due to better overall resuscitation care. So from an mechanistic standpoint, to answer this question, we asked what might be going on. So imagine 3 hospitals, Hospital A, Hospital B, and Hospital C. Hospital A has 40% of their survivors surviving cardiac arrest. Hospitals B and Hospital C are a little bit better. They have 45% survival in 100 arrests. Hospital A has this pattern of survival. So 25% of their patients survived in less than 10 minutes. So they received short durations and 25% came back early on, which is what we've seen. 11 patients survived after an intermediate duration, anywhere from an arrest that lasted anywhere from 10 to 30 minutes, and 4 patients survived after more than 30 minutes. Hospital B is better overall. They had more patients surviving the arrest at every single time point during the arrest. 28 survived in less than 10 minutes, 12 after intermediate durations, and 5 survived after 30 minutes. Hospital C is a little bit different than Hospital B and Hospital A. Hospital B is better overall. Hospital C is better than A only with respect to the fact that more of them are surviving with longer resuscitations. So if you find that survival in these quartiles is higher later on, you might make an argument that duration is actually the main mechanism behind these hospital quartiles as opposed to better care. Our hospitals in our sample, like Hospital C, where patients were surviving later. And we found exactly that. So this is showing a rest that lasts less than 10 minutes, okay? The adjusted risk ratio of survival is on that y-axis, and the over here is showing in hospital quartiles. What we found was that patients had exactly the same risk of survival, or the same likelihood of survival overall across all quartiles if the arrest was short. not significantly different. Then we went to intermediate durations and found that the likelihood of survival actually was better overall compared to patients who had a shorter risk. And the likelihood of survival actually improved a little bit going across hospital quartiles. Then the rest that lasted for a long time, more than 30 minutes, had dramatically improved hospital likelihood of survival, where the survival itself was increased overall, and it was the most pronounced at hospitals that resuscitated non-survivors for longer. So this would argue, possibly, that there's a higher likelihood of survival. It's largely due to the greater number of patients achieving ROSC late during the arrest. Again, looking at this, early arrest, the survival is the same, but later on, the longer you go, there's a lot higher likelihood of survival. The alternative explanation would be that patients are achieving approved ROSC very early on. So this would look just like this. And now I would argue that duration doesn't have as much to do with the findings, but rather that there's better overall resuscitation care. It's speculative, but this supports the idea that duration is actually playing a large role. So going back to our thought experiment, hospitals that I'm asking you to say will stop after 15 minutes and 30 minutes. Within those 15 minutes of additional treatment, something might happen that changes the prognosis of the patient in question. The large majority of the gains that we're seeing may be due to the practice of continuing resuscitation for longer periods of time in the hospitals. Doctors are choosing to go for longer. They don't stop early because patients come back, but they're actually choosing to extend how long they're going to practice the resuscitation efforts. And these are hospitals that are able to rescue potentially salvable patients just by extending 15 minutes or not. Recently, other work has somewhat validated our findings. This is a study from the Get With It guidelines that was published 4 weeks ago in Circulation. They looked at pediatric cardiac arrests, which are entirely different than adult arrests. They looked at about 3,400 children in 328 hospitals within the registry over 9 years. Instead of stratifying by duration, they're stratified by illness type. So they're looking at patients who have surgical illness, medical illness, surgical cardiac, medical cardiac, 5 or 6 illness types. What they found was that it wasn't surprising. Duration was inversely proportional to survival and to discharge and neurologic outcome. Every minute longer, they had less likely of a chance of surviving overall. But what was remarkable about their findings was that they found that you could have intact survival after 35 minutes of CPR and 16% in certain groups. And that was very surprising because what they found previously, they should have found that the overall survival in total was 16%. They found that you could have 60% survival after 35 minutes. They wanted to make the claim that this study should also dispel the common misperception that CPR is futile beyond 20 minutes. You could have a favorable probability of a good neurologic outcome after longer durations of CPR. So there are limitations to this study, obviously. First of all, this is an observational registry of secondary data. The findings may not be representative of all hospitals. Hospitals voluntarily participate. And this is a quality initiative. They may be more committed to higher quality resuscitation. We had a sample of about 435 hospitals, which is about 10% of all acute care hospitals in the United States. We found an association between duration, resuscitation, and survival, but association does not equal causality. Finally, we have to understand that the registry is very comprehensive. They have a lot of variables, but there are unmeasurable variables in there that may affect duration of resuscitation and influence bedside decision-making. Things such as co-team leadership maybe better overall, people doing better compressions. Maybe there was a family member at the bedside that affected the impact, or affected the duration. So a large potential for residual confounding, even though we had a large amount of adjustment. And finally, we're able to account for long-term outcomes after discharge. We know how many survived. We know where they went. But we don't know what happened to them 1 month later, 6 months later, or years later. There's an effort now to sort of link this registry data to Medicare claims administrative data, which may help us look at that a little bit better, but again, I have reservations about that too. Cardiac arrest plays a lot of attention in the media. So if you recall, back in March, Bolton footballer Fabrice Muamba collapsed on the field and got 78 minutes of CPR and came back without any neurologic deficits. If you're a soccer fan, it's going to be a very big victory for you. So the thing was, at the time, everyone was asking the question, would you get the care that Muhammad did? So 78 minutes of CPR is actually quite a long time, and he came back. Of course, this was young. He was a young guy, he was healthy. So it's sort of asked the question, well, maybe these findings, maybe this doesn't apply to everybody. But again, he did well. I received this news link in my email recently about a man in Tennessee who would beat the odds to recover after 109 minutes of CPR. So he got 1 hour and 49 minutes of CPR and came back, and this is fine. I thought it was interesting that the 109 minutes of CPR was actually the upper limit of duration in the registry, so perhaps this data has been circulated out to the Midwest and beyond. So he got the maximum. He didn't go any more than we would have had, or else. But again, these are in-hospital. These are not in-hospital cardiac arrests. These are out-of-hospital cardiac arrests. But again, it pays a lot of attention. And I'll just recall that the day after the study came out, I went to my office. I had a voicemail in my inbox. It was a man from Arizona who said he was happy to know that longer efforts are now being published. 8 hours. He came back fully neurologically intact. He wanted me to call him and discuss the impact of my study. I have not yet returned that phone call. So overall, what are the implications of the study? So the question is how best to favorably influence our current practice without constraining individual decisions. Are we going to be doctors or clock watchers? So perhaps standardizing the approach to ensure resuscitation attempts that occur for a minimum amount of time may improve outcomes. I'm not saying there's a certain cutoff that we should go for longer, but saying maybe we shouldn't stop until X amount of time. That would be one way of standardizing. There's such a high degree of variability, as we saw. Perhaps standardizing duration could be one way to go. And it could affect outcomes. I would say that if you extend the resuscitation attempt to more than 15 minutes, hypothetically, it may have only marginal effects on resource utilization. So you've got to imagine that call the code, the whole team is there. You open up the cache card. You go for 15 more minutes, is that going to really have a large effect on resources? I mean, resources is a very charged word, but again, that can be cost-effective studies to sort of look at this. But again, standing around for 10 more minutes may not make that much of a difference as far as resource utilization goes. And finally, this is time I think that might be well spent. You could utilize novel physiological predictors of prognosis, things that might help restore better ventilation perfusion. Things like cerebral oximetry with near-infrared spectroscopy is utilized. That sounds institutions. Pulses, waveform technology, even echo. Lots of things you could do to the patient over time that might help them to spend more time. I did the back of the envelope calculation a couple of days ago to sort of see what's the overall benefit. And this is a little bit hard to do because we're looking at sort of hospital risk ratios, but recall that this is a 200,000 patients in hospital cardiac arrest every year. 20% of them survive at discharge. So 40,000 patients are surviving at discharge. If you account for the impact of adjusted risk ratios for survival of discharge patients, so now there's 20% higher likelihood for patients with PEA over patients in quartile 4 and quartile 1. So we have a 20% higher likelihood of survival of discharge in patients with a bad rhythm. What I found was that the number increased from 40,000 to 44,000. The number needed to treat was about 4. The absolute risk was 3%. I think it's the calculations are harder to show you them, but again, we have the potential of saving thousands of lives. So how we become much better to understanding the durations of STEM? Again, a few minutes to 3 hours. In 50 years, we haven't actually come that much closer. You venture to guess, and we're cautious to actually say what the actual duration should be. There's significant variation across hospitals in how long doctors are choosing to code patients before they stop. An increase in duration of resuscitation attempts prior to termination may improve survival. Hospitals with longer efforts had similar neurologic outcomes. There's no detriment in neurologic status in the case of long efforts, but higher survival rates compared to those with shorter efforts. So you're potentially increasing the number of patients who have clinical outcomes. However, bedside clinical judgment will help balance the potential downside of longer efforts. So you're seeing more patients, but again, you want to avoid the clinical downside of futility. It's extremely important. So what are our take-home points? So there's no specific cutoff, right? We're very cautious to say you should resuscitate patients for X amount of time. You can't do that. I hope that people don't do that, take away that from the study. But overall, efforts to systematically increase the duration of resuscitation across hospitals in a standardized way may improve survival. The benefit months to years after an arrest should be the ultimate measure. Sure, you're going to have a better overall survival immediately, not discharge, but again, the benefit in the long term remains unknown, but that might be the ultimate measure of utility. And finally, the optimal resuscitation duration for any patient. And this applies to a very limited number of in-hospital patients. And the question is, which patients those are. We adjust for lots of things. And it's always going to remain a bedside decision. You have to be careful to make judgment. I would argue that the next time you're faced with a hospitalized patient in cardiac arrest, you should ask yourself whether this is one of the patients that may benefit from longer efforts trial. I just wanted to say that it's such a pleasure to be back in Washington, at Harvard especially, where we have such a long-standing tradition of resuscitation science, especially with Valentine. There's some key investigators, most of these neurologists, who become just pathway to work with this. And it's very humbling to be able to deliver this lecture to this audience. I want to thank several people. First of all, Robert Johnson, who's a scholar who supported me during this time. My mentors at the time that I was there after school, Roger and Rod Hayward, or just the constant influence. Anytime you look at constellations literature, medicine, cardiology, it's hard not to find that in the byline. Co-authors in the study are remarkable individuals. Paul Chan, Goldberger, are all people who have done pathway work with the registry. He's done great things in hospital arrest. Colin Crumholz is a household name. And I had the great pleasure over the past 2 years, really want to work with Colin Cook, the graduate program, who's just done extremely well with it. I want to thank Dr. Aaron Fouch and Neurologic for finding that listening to this talk before I gave it to you today. And I want to thank my new friends in resuscitation who also made this talk: Graham Nickel, Mike Sayer, Michael Kopis, Tom Ray, and Peter Kunchuk, who I look forward to having a long, ongoing resuscitation with them. I'll say happy Valentine's Day. And thank you. Happy to take questions. I'd also like to hear your reactions.
Zach, great talk, very interesting. So, what's the physiology? What happens? I mean, what happens in those last 10 minutes that makes somebody come to life?
No, that's a great question. I mean, that's something that's very hard to look at just from registry data. I think that what we found with patients with PA and asystole is that they are actually benefiting from longer efforts just because you're identifying whether they have hyperkalemia or you have tamponade. There's something that you're doing enables you to find out the reversible causes. But again, I think that, and they're also taking longer philosophy to respond to therapy. So, you give a bolus of epinephrine. In a patient that's very sick, it may take a long time for that to fully take effect. But I agree with you, it's a great question. The question is, what is it? I mean, it may be, like I said, that the duration is not what's going on. It's just better overall care, better compressions, more time to leadership. It's hard to know what the actual physiology is. There's not a lot of causality for resuscitation. That will require a lot more biochemical studies. We've actually done some work, non-associated done some great work actually, looking at blood samples of patients who had a cardiac arrest, so looking at their biomarkers. We should see if that would be longer efforts or not.
Did all of these measures have continuous cardiac compressions and normally
we looked at manual compressions. They were all manual. That was one of our covariates we just explored. I don't think that there are a lot of hospitals, I don't actually know that there are not a lot of hospitals that are doing things with a mechanical device. It would be very interesting to see whether that degree of compression affected outcomes, whether that actually better or worse. But there are continuous compressions that we were in hospital beds.
great presentation. One concern that we've had in the area of resuscitation, which I'm curious about your perspective, is how soon the plug is pulled by hospitals after a patient is resuscitated. And I'd be curious in your evaluation of these longer durations of resuscitation, where the hospital is also committed to allowing a longer period of time for recovery from that resuscitation event. So such that it was not only the duration of the event, but the duration after that may also be considered.
Yeah, so the issue of how long is life after death is a huge issue. And the question is, are we looking at after death? What is the post-resuscitation care? We don't have a lot of evidence about that. Patients who are resuscitated a long time, we don't know the long-term outcomes. The question is, how long we should. The question is, how well are we doing after they is not known. It's definitely a very controversial issue. They may come back, they may survive the discharge, maybe not a lot of them do. I think that future efforts must be directed toward not just getting them back, but certainly how we're treating them afterwards. So let's hope to sustain their quality of life beyond the time of discharge. Very interesting question. I'm curious to know what your other perspectives on that might be.
Yeah, I think it's really provocative data and one of the great applications I think this type of data would be is informing discussions with patients. And I just want to get your opinion on your findings, how this actually changes the type of discussion we should have before the case happens.
Thank you. That's an excellent question. So the question is, this analysis is directed at not when to stop resuscitation, when to stop. When do you stop at this point? The larger question is whether patients should be resuscitated at all. And I think that we found actually that DNR orders are oftentimes only signed 48 hours before the initial event. This evidence that was presented would argue that the one way to actually ensure better outcomes might be to really spend a lot of time knowing about when you should actually decide to put something out. One potential take-home message here is that there's something called short codes, where the patient is full code, but you're going to go there not with the intention of what the definition of resuscitation is, which is to save life. So you go to do these short codes. I think those things should probably be eschewed in practice. That deciding, really spending a lot of time with deciding who you're going to resuscitate will make a huge impact. Because we've shown that potentially longer patients will be better. And I don't want people to walk into the hospital thinking, well, it's okay if I haven't dressed because let's go for a long time. Back. That's a message that I don't want to put out, but unfortunately that won't be the case. I think that having a long, lengthier coaching session is paramount in ensuring improved outcomes. I hope that we all remember that the issue is not when to stop, but oftentimes it's more important to ask yourself when to start.
Did you mention the time between cardiac arrest and first attempt for resuscitation, specifically in the out-hospital setting?
We actually only looked at patients who had index arrests inside the hospital. So these are de novo arrests in the hospital. So we looked at time from event to first impressions only in the in-hospital setting.
So I thought there was a limit if it went beyond 8 minutes that resuscitation was not indicated anymore. Outpatient setting.
That may be the case. I can't comment on that specifically. This is hospital.
Thank you very much. Other questions? Thank you.